Sorry about that. I'm already showing y'all slides that I'm not ready to get into. Okay, so this is our Zoom recording for chapter 22, and these are our slides on the endocrine and nervous systems. It starts on page 558 of your step-by-step manual. So we're just going to go through these slides. There's not a lot of them. Excuse me. So here we go. There are 9 glands in the endocrine system. Only 4 are included in this subsection: the thyroid, the parathyroid, the thymus, and the adrenal. Pituitary and the pineal are in the nervous system. Pancreas is the digestive system, and ovaries and testes are in the respective male genitalia system. The respective genitalia system. The endocrine system, 60000 through 60699, divided into 2 subheadings: thyroid gland and parathyroid, thymus, adrenal glands, pancreas, and carotid body. The endocrine system, and your number range is 60000 through 60699. The carotid body refers to an area adjacent to the carotid artery that can serve as a site of tumor excision. The carotid body is rich in capillaries and acts as receptors of the carotid arteries. And you have a little picture there. Thyroid gland excision, 60100 through 60281. There are 2 lobes. Code descriptions often refer to partial or subtotal. Something less than total is going to be your subtotal or partial. Removes problem site of the gland, the isthmus, and majority of the opposite lobe. Total means all. Lobectomy, partial. Total thyroid lobectomy, solitary nodules, follicular, adenomas, nodules, and goiters. Nervous system is divided anatomically: skull, meninges, and brain, spine and spinal cord, extracranial nerves, peripheral nerves, and tongue-tied, autonomic nervous system. Okay, skull and meninges and brain, 61000 through 62258. The categories are injection, drainage. I'm going to move my picture up a little bit because I can't see. Sorry. Here we go. Or aspiration, twist drills, burr holes, or trephine. Meninges are 3 layers of connective tissue membranes that surround the brain and the spinal cord. And again, you have your little picture here that you can refer to. Skull, meninges, and brain, conditions that require openings into the brain to relieve pressure, insert monitoring devices, place tubing, and inject contrast material. Procedures in the craniectomy. I got to move myself again because I can't see. Procedures in the craniectomy or craniotomy category are reported with codes 61304 through 61576. These procedures deal with an actual incision of the skull with possible removal of a portion of the skull to open the operative site to the surgeon. Skull, meninges, and brain, craniectomy or craniotomy category 61304 through 61576. Removal of portion of skull, usually as operative site. Codes divided by site and condition. Lesion removal at the skull base is very complex and often requires the skill of several surgeons working together. Coders should read the extensive notes provided in the CPT manual. Of course, you guys know that no matter what, you always need to be looking at those guidelines, the rules and regulations, and researching if need be to see about how to code a specific section. Surgery of skull base category. Skull base, the area at the base of the cranium. Lesions removal from this area very complex, extensive category notes. Surgical management of lesions in skull base often involve surgeons from different specialties working during the same operative session. The approach to the procedure is, oh, sorry guys, let me get back. The approach procedure is reported with code 61580 through 61598. The definitive procedure reported with code 61600 through 61616 refers to what is done to the lesion. For example, a biopsy or an excision. The repair or reconstruction procedure is reported with codes 61619, 61618. I said them backwards, but you know what I mean. Surgery of skull base terminology, approach procedure used to gain exposure of the lesion. Definitive procedure, what is done to the lesion. Repair reconstruction procedure reported separately only if extensive repair. If the same physician performs both the approach procedure and the definitive procedure, both would be coded. The lesser procedure, the approach, should have a modifier 51. If different surgeons, each performing their own portion, approach definitive and repair, then each surgeon would code their own portion separately. I just can't seem to find a good spot for my face here. Let's try down there. Surgery of base of skull. Example, removal of an intradural lesion using middle cranial fossa approach. 61590 is the intratemporal prearticular approach procedure, middle cranial fossa, and 61608 definitive procedure of intradural resection of the lesion. A shunt, what is a shunt? Is a draining device used to drain fluid from an area of the body that is not able to perform this function on its own. Cerebral spinal fluid, CSF, shunt, 62180 through 62258. It's used to drain fluid. Codes describe placement of devices, repair, replacement, and the removal of shunting devices. The spine and spinal cord subheading includes code 62263 through 63746, which are used to report injections, laminectomies, excisions, repairs, and shunting. Codes divided on condition and approach. Other important coding considerations: unilateral or bilateral procedures are going to use modifier 50. Multiple procedures, modifier 51. Radiologic supervision and flora guidance reported separately. Spine and spinal cord, 62263 through 63746. Many codes in the nervous system involve conditions responsible for the procedure. For example, abscess, cyst, hematoma, foreign body, tumor, etc., as well as the technique used for the operation. Remember, you need to review your CCI edit. Introduction, injection of anesthetic agent, diagnostic or therapeutic, 64400 through 64530. Include codes for nerve blocks, and there's your code range. Facet joint injections, again, code range. Epidural injections, used to provide pain relief. And that's the end of the endocrine and nervous systems. It's a very, very quick little slideshow. I hope you forgive my tongue-tiedness. I don't know why I get so tongue-tied, but I appreciate you guys so much. You're doing a great job. And I will be talking to you later. Bye-bye.